Thanks for inviting me to talk today. So I'm talking about dealing with a family diagnosis, which is pretty much the bread and butter of what I do. I'm a genetic counsellor. I don't know if any other genetic counsellors are here, or if anybody's seen a genetic counsellor. So as Lara said, I work for the National EDS Diagnostic Service. I actually work in Sheffield, not London, but that's fine. And we were set up about 10 years ago, specifically for the rare types of EDS. Does anybody in the room have one of the rarer diagnoses? I'm looking to see if I can anybody. So hypermobile EDS, or hypermobility spectrum disorder, is much bigger in terms of the numbers of the diagnosis, but we don't see people with that diagnosis in our service. We're set up specifically for the rare types. We have two bases, one in Sheffield, one in London. So where I work in Sheffield, we see people from Scotland. I think Shetland is probably the furthest place that we've had people coming from. The referral criteria are on here. I won't read them out, but basically all referrals are triaged, and we see people where a diagnosis of the rare type is suspected, or also where it's been made and people want some further information. So this is our Sheffield team. We have two consultants, Diana Johnson and our lead consultant, Glenda Sobey, and between them, they are one full-time equivalent, so they share the role. And we have three genetic counsellors now, so I'll put them out here if I can see that's me, obviously, and Claire and Tammy are my colleagues, and again, between us, we work as one full-time equivalent, so we all work part-time. In fact, the only person that is full-time is our wonderful coordinator, Yvonne, who keeps us all running, basically. So, what is genetic counselling? What do genetic counsellors do? So we work with individuals and families who may have or be at risk of a genetic condition. We help people to understand and adapt to the medical, the psychological, and the family implications of how genetics contributes to a condition. And we support families and individuals in discussions about test results, interpretation, prevention, management, and options, particularly in terms of prenatal diagnosis. But we're not medically trained, so I'm not involved in diagnosis, which is why I work alongside the consultants. So in the UK, we have the Genetic Counselling Registration Board, so I'm a registered genetic counsellor, and we have the Professional Standards Authority over holding that registration. We have the GCRB Code of Conduct, what we work under. I'm also in the Association of Genetic Nurses and Counsellors, and the AGNC has a Code of Ethics as well. So we work under professional standards. So what makes genetic diagnoses different? So genetic diagnoses are family diagnoses, but first of all, you have the person being diagnosed, and they're going to have implications for themselves, whether that be in terms of screening for themselves, management, looking at the risks. But then they're also going to be finding out about the implications for their current or future children. And then they're going to be finding out about whether there's any implications for the wider family. So there's a whole lot of different implications for genetic conditions aside from just for that one person. Genetics uses lots of scientific language, so one of the first things that we do when we see people is make sure they understand the terms that we're using. Do they know what a gene is? Do they know what a chromosome is? And inheritance patterns are kind of key to understanding how genetic conditions run in families. And this can sometimes feel like taking people back to school. Some people respond quite well to that, find it interesting. Some people have a little bit of a fear of science school lessons. So we really have to make sure people are on board with the information and that we know what their prior sort of understanding is and whether they've got any assumptions that they've made on the basis of their family history. So the common thing is, it always affects the firstborn, and that sort of thing is got to be kind of clear to work out what people are thinking, to unpick that, and then make sure they've got the right information. Genetics results are not always clear-cut, so even when we've got a clear genetic diagnosis, we cannot always confirm that with a genetic test, and also we get results that we can't currently interpret. So we have to make sure people understand what we can and we can't understand currently with our technology. Genetic diagnoses come with a lot of decisions. There are often no right and wrong answers, and that's really the background to genetic counselling, making sure that people are making informed choices, making choices for themselves and not doing what somebody else would do. And that can be in relation to their own management, and screening is really important in prenatal options, making sure people are doing what they want to do and not feeling any pressure. And comes into the case in terms of testing children as well, and looking at when that is done and how that's done. So, we've been talking quite a lot today about EDS, but mainly in terms of hypermobile type and hypermobility spectrum disorder. Is this list familiar to people in the audience? Getting some nods? Great. So this is the 2017 classification, the 13 different types of EDS that were included in that classification. So as I've mentioned, we don't in our service, we don't see people with a hypermobile type of EDS, but we do see all the other types of EDS. Having said that, the majority of them are extremely rare. So in my 10 years, I've met one person with brittle cornea syndrome. But the majority of my caseload is made up of patients with the vascular type and the classical type of EDS. So I thought I would focus a bit on the vascular type of EDS today, if that's all right. So this is the current diagnostic criteria. And I won't read it all out because I'll be here all day. But the main change from previous criteria is the importance of confirming the diagnosis with a molecular result. So everything else in the criteria is really just clues as to when you should be doing genetic testing. So I'll give you a second to have a look through that list. So there's the major clues, and then there's the minor clues. And the minor clues are quite non-specific. So people often talk about a facial appearance, attached earlobes. I think if you spent time looking at the break today at people's earlobes, you'd find that attached earlobes are not that uncommon, really, not that helpful in terms of making a diagnosis. And sometimes that we find in the clinic when we're seeing people is that before we've got the test result, we're kind of there going, oh, could they, maybe, is there a clue? I'm not sure. And then after we get the result and we find that somebody has got a diagnosis of vascular EDS, it seems so much more obvious. And we can say, oh, yeah, it's you know, clear cut. But before you know, it's really not that clear. Easy bruising is also a feature. Easy bruising is really tricky again. Is easy bruising because they're spontaneous bruises, or is easy bruising because people are actually bumping themselves more often? I can self-declare as a non-hypermobile person, I'm extremely clumsy and regularly have bruises. And if you include people that are hypermobile with poor proprioception, you're going to have regular bruises. So the clues that we look for are sometimes where those bruises are. So you can see here, a bruise under the arm, it's not that usual, or a bruise above the knee. So sometimes they can give us little clues. Visible veins, I don't know how well this picture projects. Can you see the visible veins? Not that well. So it's really common for people with light skin to have visible veins. But what we look for is the pattern. Sometimes gives us a bit more of a clue. A bit of a sort of more unusual pattern of those veins can sometimes suggest something more. And the last picture is just to show the medical emergency card that we've produced. So all patients who have a confirmed diagnosis of vascular EDS can get a copy of this card. And we think it's really important. So our patient pathway, as I mentioned, our referrals are all triaged, and the referrals that meet our criteria are then put into a clinic appointment. Before that appointment, we have contact by phone. So one of the genetic counsellors will get in touch with the family, and we'll take some family history, some medical history. We'll find out what their questions and concerns are, what they're expecting from the appointment, and also let them know what actually we can do at the appointment, so that they've got realistic expectations. At the clinic, it will usually be the genetic counsellor that's made contact with the family, who will be there alongside the consultant. And again, we'll go through medical history, family history, and do a clinical examination. At that point, we may have a discussion about the fact that there isn't anything else that we would suggest doing and discharge them, or we may suggest doing some genetic testing. Testing is done in various different ways. We may look at a single gene, we may look at a panel of genes, we may occasionally do skin biopsies of urine samples, but we're always clear to make sure people understand what they may get back from results, because we know we don't always get clear-cut results. Any results go through our MGT, so the consultants, genetic counsellors and scientists, and we'll discuss results to make sure we're getting the right information for people, and then give those results back to people, and depending on what's needed, go on from there. So I've mentioned one of the first things that we always do is draw a family tree. So this is the symbols that are used in medical family tree drawing. And it's really, really helpful for us to know. If there's nothing similar in anybody else in the family, that's really important for us to know, as much as if we can see a pattern or the clues that we can piece together. So simply, squares for men, circles for women, and this bit at the bottom is the key bit, really. So you do a line between the parents down and above the children. It's slightly scary, the number of GP family trees I've seen where the siblings seem to have had children together. So you've got to make sure you've got your lines in the right place. And we do keys generally to show what conditions we picked up on in the family. Sometimes colouring in the square, a circle, or shading, or just a little kind of clue that we put into a key so other people know what we're talking about. So I thought I'd give a sort of an example of what I do in terms of dealing with a family diagnosis by talking through a case. This is an anonymous case. In fact, it's kind of a bit of a combination of families, so not strictly one individual case. But going right back to the beginning. So this is a referral that we've got for a male. He's 43 and he's just recovering from an iliac artery dissection. So at the point of referral, we had a discussion about what's happened for him. He presented with groin pain, went to A&E, took a while to work out what was actually going on. And in the process of that, finding out, he was managed conservatively. He didn't have stenting or anything. And he's making a good recovery. He has been knocked by this diagnosis because he was a very sporty person. He's wondering whether the bike ride that he did the day before had any contributing factors or not, but he's very anxious now about what he does in terms of activities. And we were able to kind of talk through that initially and talk a bit about his family history. So the first thing that he told us was that his sister had died, exactly the same age, 43, and she'd ruptured her aorta, and he can't help but connect these two. The same ages, he's brought up all the emotions again for what happened with his sister, but he's also feeling relieved that he's still here, but he's anxious about what it could mean for him. He's wondering if they're connected, and it's brought everything up. And you know, although he's doing well following his direct dissection, he's worried about what the future's going to bring. So we had to be honest. We also wondered if they could be connected, and we offered him genetic testing. So we looked at a whole panel of different genes associated with blood vessel rupture. And we had to explain to him that the results may not show any changes in any of those genes. They may show a change that we knew exactly what it meant. So a pathogenic variant in one of the genes that we could say this is a diagnosis of this condition. Or it may reveal a variant that we couldn't currently interpret. So what we know is a variant of unknown significance. And that these are really tricky because we just don't know what they mean. So we can't give any helpful information at the time about them. And they do cause a lot of worry. So he was happy, gave consent to go ahead with testing, and we did that. And the results of that show that he has a pathogenic variant in COL3A1, so the gene associated with vascular EDS. So we were able to give him this as a diagnosis. It came as a shock. He'd not heard of this condition before, but he was kind of expecting there might be something given his family history. But it was a second thing to get his head around. He'd got his head around the dissection, and now we were bringing in a whole new load of other information for him to think about. So we talked about what it meant for him. We talked about medical alert. We talked about referring on to our cardiac clinic, and sort of what activities he should be thinking about avoiding for himself. And then we talked about the family implications. So we extended the family tree. He actually has 5 children, and you can see from this that their age range is very wide. So his eldest daughter, 17, his youngest daughter's 3. So we had to talk about the implications for them. So firstly, we talked about the inheritance pattern. Everybody has 2 copies of the COL3A1 gene, but somebody with vascular EDS has a mistake affecting one of those copies. So we know that when he or anybody with vascular EDS has children, they have a 50-50 chance of passing it on because they pass on either the copy with the change or the copy without. So his 5 children each had a 50-50 chance, and that's like tossing a coin. It happens each time. There's no memory, so it's not that half will and half won't. It's just a 50-50 chance each time. And one thing that we work closely with in our genetic counselling practice is consent and confidentiality. So with genetics, we always have to make sure that we are maintaining that person's confidentiality. So the person in front of us is our patient. But we know genetic information is relevant to other people in the family. So we have to make sure that we use a balance of maintaining confidentiality whilst helping that person to share the information. So we were able to talk to him about what he said to his children at different ages, how he spoke to them, and look at what they might understand at different ages. So use some really sort of simple techniques like making sure that they knew that they could ask questions, because that really gives you an idea of what their understanding level is. And if they know they can ask questions, then they can really sort of understand at the level that they need to. So the questions that an 8-year-old asks you will be very different to the questions a 17-year-old asks. One of the things that we do in genetics is we take consent to share information before we do any genetic testing. So at the point in time when somebody is having a discussion about genetic testing, we actually take consent for that information to be shared with other family members. But we can't go and tell anybody that information. So we have to work with them to help them share that information. But if somebody gets referred to us or to another genetics department, that information can be used to make sure the person in the family gets the right information. So we had his consent to use that for other people in the family, but he has to be the person to tell people. We can't cold call people. That's not allowed in our profession. So we really tried to make sure that we were supporting him in passing this information on through the family to his children and then to other family members. So he has a 50-year-old sister who's not had any problems and doesn't have any children, so he wasn't sure whether she needed to know. So we had to talk through the condition in terms of what it meant for her. Vascular EDS, we have a lot of evidence now that it is much better to have the diagnosis known. People are a lot safer when the diagnosis is known than when it's unknown. So we made that clear and helped him to share that information with her, using letters that she could take to a GP and get referred so that she could get the information in her own right. We also knew that it was likely his sister had the same diagnosis. And this was a bit more difficult for our patient because he wasn't in touch with that branch of the family anymore. He felt very guilty about it. He was beating himself up quite a lot about the fact that he hadn't stayed in touch. He hadn't had a great relationship with his sister's husband before she died. After she died, he just didn't see there wasn't any kind of reasons to keep the relationship going. But he knew that that wasn't very fair on his nephews, and he was feeling guilty about that. They were into their late 20s, and he thought they might even have families of their own, but he didn't know anything about them, where they were living, what was going on. So we had to look at how he passed that information on. Usually, we find it's very rare for us to meet somebody who won't pass the information on, who doesn't want to, doesn't think that that person should know. But we do know that it's not always easy for people. So we had to look at, did he know anybody that was still in touch with them? Was there some way that he could get through to them? Could he get in touch, let them know there was information, and just let them get it from us directly if they wanted it? So we had to work through kind of how that happened. And then we were talking about his parents. So genetically, given the fact we've got a brother and a sister, both likely to have the same diagnosis, we're going to think one of the parents has also got it. But there wasn't really much in the way of clues there because his parents were both in their 70s. His mum had early varicose veins, but actually that was after pregnancy and not necessarily related. So we didn't know, but we see this in our vascular EDS families. We see it in all different conditions, that conditions are variable, and it's not uncommon for us to find that parents have not had any signs of this. But we think it's still really important for them to have the information for 2 reasons. One, for themselves, to make sure they've got the information. They may want it, they may be in their 70s, but having a very active lifestyle, and maybe would be helped by having a bit of guidance about what they should and shouldn't be doing on the basis of this condition. And the other reason is the extended family. So we found out that his mum was an only child, but his father had 9 siblings. So we call it cascade testing, or cascading the information through the family, because what we find is that once somebody else has the information, and if they're found to have the same condition, you can then go on to a whole another branch of the family, and it can keep on going, cascading through families. So there's potentially a whole number of different branches of this family that this information was relevant to. So I tried to summarise how we deal with a family diagnosis, and my summary is by no means an exhaustive list. It's just a little overview, I think. One thing I think is that it takes time. I talk to people about, really taking a good year from when you're diagnosed to get your head around things. There's so many ups and downs in that first year. There's appointments, there's other people in the family being seen, there's results. It's a roller coaster. But if you can look back in a year and reflect on then how you feel about the condition, and are you managing to live first and have the condition second, or is it still kind of predominating in your life, is something that I think people need to take time over. It's ongoing. It never goes away. It's always there. What we would like it to be is a bit in the background, but it's always going to be popping back up with any concerns that people may have, whether that be a big bruise or something more worrying. It's always there, and it's always important that people take notice of it with vascular EDS, because they need to get things checked out. It changes. Families change. New people in the family are born. People age, that's normal. And the implications change over different periods of people's lives. And one of the main things, I think, is that it requires support. So that may be family, friends, that may be medical professionals, that may be, we've talked a fair bit about it this morning, but the different talking therapies to help people cope and adapt to this new diagnosis. But one of the main things that we work really closely with is support groups, because we know how important support groups are for families. So EDS International, EDS Support UK, Annabelle's Challenge, specifically for vascular EDS, we work really closely with them because we know how important they are in dealing with a family diagnosis. And that's the end of my presentation. So thank you.
Okay, so we're going to get through some questions, and if anyone has questions in the room, Yuda, we'll start with you at the back. Hey.
Hi, I have a question about genetic counselling. As I understand it, there's no counselling for hypermobile EDS on the NHS. If that's right, can you explain what the reason for that is, and whether there's any chance of that changing?
Thank you. A bit of background. So I've been working in the genetics clinic for 15 or so years now. And when I started, we did used to, in the general genetics clinic, so separate to the specialist service, we did used to accept referrals for hypermobile EDS. But the numbers of those kept increasing, and I think the majority of genetic services now have said there isn't anything that we can offer in genetics departments for people, families with hypermobile EDS. And that is really on the background of seeing a lot of people feeling disappointed with what they got from the service. And we don't have physios attached to our service. We can't manage the condition in genetics. We have no genetic testing to offer in hypermobile EDS at this point in time. Whether that will change in the future, who knows? But that's really the background to a sort of a process which has led a lot of genetic departments, including Sheffield, where I'm based, saying, actually, no, we can't accept these referrals because we can't offer what people want. We're going to get them disappointed, and actually it's not the right use of NHS resources.
Okay, adoption complications. How does being adopted and not having family history impact diagnosis, particularly when the criteria is borderline for person X, but no parental history of EDS to validate the other assessment criteria bucket?
So it is something that we are really used to in genetics services, is taking into account when people cannot get the family background. It is very normal for us to not have all the information, even when people have, some people come with family histories going back centuries, but you're not going to get the right information even in those. So it's something that we're used to working with, and we will take into account. And we do what we can do in terms of getting the right diagnosis for somebody on the information that we have.
Thank you. One for Tanya. Children are undiagnosed, but highly suspected EDS. How do you broach the subject to paediatricians, and what do you tell school? I feel as though schools think I pander to my children, but I know how much pain they're in.
Well, as I said in the talk, what you need to do is educate them, take the resources from websites, print them off. You just have to convince them that this is the case, this is the information, this is how my child's symptoms match up with the information that's on this sheet. What was the other bit of the question?
Hang on a second.
I've got no memory either.
Sorry. Basically, feeling as though schools think I pander to my children, but you know how much pain they're in. So it's kind of knowing.
Yeah, I mean, as I say, you've got to be a warrior for your child. You have to advocate for them. I remember times when I was just exhausted and just feeling humiliated because people didn't believe me, and I couldn't do it anymore. And then I would just have to remind myself, it's not about me. It's not about how I feel about something or how embarrassed I am because it's about my child and their future. And then I would just get up and do it all again. But I think, join some of those Facebook groups, and any forums to just get that support. You just have to keep at it and at it and at it. There is no magic word, there is no magic wand, but it's tiring, it's draining, but ultimately your child is worth it, so you've just got to keep going.
Thank you. And one for you, Jess. I've been ostracised by family members for trying to educate them about EDS and HSD. What are the best ways to deal with family who deny or are angry at you for mentioning the hereditary nature of EDS to protect them or their children?
Oh, that's a good question, isn't it? Sorry, I'll put this on. That's a good question. I suppose it's working with your family and letting them come to you when they've got questions to some extent, because sometimes when people don't want to hear things, it's because it's not relevant to them at that point in time. I'm not sure. I suppose knowing your family, and the best way to communicate with your family sometimes is giving them a bit of space, letting them know that they can ask you questions about a condition when they want to know more. It depends on what your concerns are for them, really. If you feel like they really need to be accessing some help, maybe that can be along the mental health side of things sometimes, as much as the physical side of things, but being open with them and being there for them to some extent, I suppose. It's not always easy in families.
Thank you. Question for Natasha. Do you regret finishing your law degree based upon the toll it took on you? If you had known, and you could do it all over, would you have maybe changed your path and your dreams earlier?
That's such a good question, and I can't say that I haven't actually asked myself that. But I do think that it was really important that I finished what I started. What I did with it after I got my degree, was irrelevant, really. I feel like I needed to prove to myself that was possible, and it was. Whether or not I'm using it now, I don't know. But what it did was train me to be resilient. And it's easy to think about what EDS takes from you and what you lose, but you do come away with a lot more than some other people might, in terms of being, your determination and your resilience through the hard times. And I can now apply that to this new career that I have. And I'm able to get through things that perhaps other people aren't yet able to, because my law degree and the difficult time that was, it trained me for it. So, in essence, I'm really glad that I did it.
Thank you. Question for you again, Jess. What do you suggest when you have a family history of spontaneous organ rupture, but you can't get anyone to refer you to genetics?
Speak to your GP. If you have a family history of spontaneous organ rupture, take some information about it to your GP and speak to them. I think most GPs would take notice of that. They should do.
You'd hope so.
Yeah.
And I think that goes back as well to what was said earlier, that you do have the right to change your GP. And I think time and time again, people don't realise that. And so if you're not getting anywhere with the GP that you have got, you have the right to change that GP.
It's also worth thinking about where the family history is. So, are we talking, quite a number of relatives away from you or directly related to you? It's just worth mentioning that.
Tanya, with so many overlapping symptoms and prevalence of misdiagnosis and overlapping diagnosis, how do we really ever know what's going on for us when you're thinking about diagnosis and the comorbidities with children?
Well, you don't, do you? I mean, let's face it. EDS is the most perplexing, infuriating, upsetting condition, because at times, if your child has one particular symptom, sometimes it's quite clear where it's coming from, but other times it could be anything. And most often, I think it's probably a combination of everything. And I think that it just helps to just sometimes take a step back and get your head out of it. And, look at the world around you and take a deep breath. Go and do something else for yourself as a parent as well. So that because I see parents who just become obsessed and so angry because they can't get what their children need, because they're constantly denied, because there is always things put in the way for whatever reason. And it consumes them and ruins their life, ruins marriages. So I think my advice would be that you do have to take that step back and make some time for yourself and for your partner and your other children as well, now and again. However, whatever that means for you, whether it's even just like a walk in the park or some breath, because it doesn't make sense. We don't know all the reasons for everything in EDS. And so it can just drive you mad trying to figure out what's what. You just have to accept it. It is what it is, and I'm going to just have to deal with what is in front of me right now. But remembering all the time the other members of your family as well.
Thank you.
I'd just like to say, for anyone that's a family struggling with children, just our little story, which backs up basically Tanya's and amazing advice, and Natasha's amazing inspirational story. Basically, myself and my daughter have both got EDS, and with the help of the amazing Alan Hakim again, who's not here at the moment, but and various other doctors as well, and my wonderful husband and father, who's really helped us. Lucy had a lot of support through school, through university. She graduated with a first from Birmingham University, and she is now living in the Netherlands independently and holding down a full-time job in a top international firm. So we're really proud of her. And just to say, there is hope, and if you take all the support that's available, then things can really work out. So just wanted to say that, and thank you for all your advice and stories today. Thank you. Thanks.
Hi, Natasha, I just have a question for you. And Tanya, thank you for what you were saying also. As a parent of my daughter here behind me, who's 27 now and was diagnosed 5 years ago by Dr. Mittal. As a parent, I got consumed for the first 2 or 3 years because I have a science background. So I was studying everything, and I was in her face, giving her too much information. And I stood back, taking my head out of, and I have another son and happy. So it's making the house happy. I live day to day now as well with the condition. But I just want to ask you, Natasha, you mentioned your loving parents. What qualities would you say were the best? Like, was it being there listening, or was it sometimes pushing you? Or so just if you could sum up a few words even of what your parents gave you in those times.
They supported me through the entire time that everyone else was doubting me. And I think that was the most helpful, quality really that they offered. The fact that there was somewhere that I was not questioned. They didn't tell me I was an attention seeker or a hypochondriac or a psychiatric patient, or it was just relentless support. And when you try and get that support from other places, it can often come with, but maybe you're just anxious. And I think having parents that were just 100% on my side all the time made all the difference and made it far easier to cope with the situation.
Thank you. I think a perfect way to finish on that, I think to any parent, partner, friend, to all of you, the hundreds of people listening out there on live stream, the biggest gift you can give to anyone living with this is validation, above and beyond anything. It's what everyone needs and wants, not just in EDS, but living with any chronic condition, any condition really, and it is so often not given to us. And I think it's very, very important that we remind people of that, and people sometimes want to go to the ends of the world to try and give you the cure and the treatment and the funding, and just simply belief and validation would make all the difference. So to everyone listening that's caring or loving someone living with this, that is the best gift you can give, and keep giving.